So welcome everyone, and especially thanks to Trinity for taking time out of his very busy day to join us today. It's a pleasure to introduce somebody who really needs no introduction. Trinity is co-director of the GBCI and a professor in the Brady Urological Institute. He's our institutional expert on all things bladder cancer, among other things. And today he's going to be talking about staging. As I mentioned just a minute ago, we're going to go ahead and take questions in the Q&A. You can also put them in the chat. We'll go ahead and compile them all and ask them in sequence at the end. And so without further ado, Trinity, thanks again for joining us, and we look forward to your presentation.
Thanks, David. I'm going to share my screen. Could you tell me if you can see?
We can see your screen.
You can? Okay.
We can see it now.
Yep.
So
that's the speaker view. There
okay.
You go.
Can you? All right. So everybody can. I don't know if there's anybody out there. All I see is y'all's names, but I guess I assume that we have attendees. Is that right?
We've got right now 43 attendees.
Okay, great, perfect. Well, thank you, David, for the introduction. And my the title that I have today is Bladder Cancer Staging and Standards of Care. So I will say that the purpose of my presentation today is not to give you an exhaustive sort of list and presentation on everything related to staging and standards of care, but what I'm going to try to do is sort of give you the basics to understand sort of how to manage bladder cancer and as it relates to localized disease, non-muscle invasive bladder cancer, and the like. Some of the things that I'm going to talk about today have been touched upon by other presenters. But I think the purpose, at least from the way I interpreted this title, is that I wanted to be, it's going to be a little generic and go into a lot of different aspects of bladder cancer management. I welcome lots of questions, and I will be happy to answer questions. I assume somebody is doing that for me, gathering those questions, so I'll let that happen. These are my disclosures. Nothing really relevant necessarily to this presentation today. So urothelial cancer, common sort of stats that you'll hear, about 80,000 people diagnosed each year. I'll go over what that means and break that down in a minute. Importantly, there are about 18,000 deaths a year. The median age of diagnosis is 73, so sort of this is really a disease of aging. Interestingly, though, today I saw 3 young women that are in their 40s and one in her early 50s that were just diagnosed with bladder cancer. So, but the average person diagnosed with bladder cancer is a man, usually in their early 70s. It's heavily associated with environmental exposures, including smoking. Its presentation is something that is very obvious to us that deal with this, but a lot of people really will ignore things like painless hematuria, which just means that, you know, when you go to the bathroom, you see a little bit of blood in the urine. A lot of patients will recognize this as being abnormal, but not necessarily make a big deal of it or seek attention. But what I will tell you is if you're a man or a woman and you have blood in your urine, that is abnormal and it should be evaluated. And that's a message that needs to be presented to lots of both patients, advocates, patients, and their providers. The most common is painless hematuria. However, also very common symptom is urinary frequency, urgency, and dysuria, which just means pain. This is very common for women. So a lot of women will present and their gynecologist or OB or primary doctor thinks they have a urinary tract infection and actually treat them without necessarily going into a full workup. When you have advanced bladder cancer, you start to have more symptoms, in particular pain in the bladder, pain in the back from obstruction, and actually sometimes you can actually feel the mass. The evaluation is actually very simple, and it is really straightforward. CT urogram is oftentimes performed for patients that have blood in their urine or had the symptoms as I described. It is where you have a CT imaging of the kidneys and ureters in a special way that allows you to be able to see the urinary system. Urine tests like cytology are oftentimes performed, but they underperform. And what I mean by that is they're not very accurate, they're not very good. So really the gold standard is cystoscopy, which is just placing a little scope inside your bladder to look around. And I'll show you examples of what that looks like. A cystoscopy can be done very easily and effectively by any urologist. It's every urologist that's ever been through training knows how to perform a cystoscopy. And we'll go over more what a TURBT is in a minute. Just to drive the point across is that bladder cancer risk factor is tobacco use. Is very clear that exposure to nicotine and tobacco smoking puts you at a 2.5 to 3-fold higher risk of developing bladder cancer. One thing I oftentimes get asked is secondhand smoke a risk factor? Very hard to be able to define that and quantify it. So the answer is we don't know. But if you were to have secondhand smoke exposure, it would have to be a very high concentration for a long period of time. So probably unlikely. There are different carcinogens in nicotine and smoking that cause that. And it's actually those carcinogens we use actually in the lab to induce bladder cancer. So this is clearly the #1 risk factor. The #2 risk factor I will tell you is age. This is a disease of aging. Every decade of life that you get old, that a man and a woman age, it puts them at higher risk of bladder cancer. Other risk factors include occupational exposures, including things like aniline dyes, aromatic amines, textiles, hair, people that are in the hair industry, chemical industry, people that work in labs. Once again, has to be high concentration, but this is other potential risk factor. And the other question, I don't have a slide on this, but I wanted to sort of drive the point, is that we're now learning, especially in the last 24 months, that we never really thought that urothelial cancer was a hereditary disease that was passed on, but we're now learning that this is likely. There are a number of germline mutations that may predispose patients to urothelial cancer. And we can talk about that later if you'd like. Since this is a talk on staging, I thought I'd show you the actual first staging of bladder cancer. Dr. Jewett, who was a urologist here at Johns Hopkins in 1947, came up with the first staging system of bladder cancer. Here it is. This is it. Pretty amazing that the first bladder cancer staging for non-muscle invasive bladder cancer, which is here in this slide, is Group A, actually was found on 3 cases. On 3, he came up with this as on dissecting 3 cases. So let me tell you how this study was done. Dr. Jewett and his medical student that he was working with, Dr. Strong, in 1947, published this paper in Journal of Urology, which did cadaveric dissections of a number of people that actually died potentially of other causes, also of bladder cancer. And what he showed is that Group A was superficial tumors. This would be considered non-muscle invasive. Group B was patients with muscle invasive disease and early muscle invasive disease, and then people with more advanced disease that had tumors growing outside their bladder, where he was showing that in the perivesical lymph nodes and in the pelvic lymph nodes, he was finding a significant amount of them with early metastasis. So these were sort of the uncurable, potentially curable versus curable diseases. So this was not a long time ago, in 1947. Here's our current staging system, which is much which is much clearer, where we're looking at a much clearer delineation of the disease. And when you look at staging, it today could be staged as non-muscle invasive bladder cancer, or muscle invasive bladder cancer. When you look at non-muscle invasive bladder cancer, 70% of all newly diagnosed bladder cancers are non-muscle invasive, which means that if you take every new diagnosis, 7 out of 10 people are going to be diagnosed with non-muscle invasive disease, and the majority of these are going to be superficial tumors and low grade. So the good news is we catch a lot of these tumors at an early stage. But about a third of these are going to be high-grade cancers with either invasion into the lamina propria or CIS, or carcinoma in situ. And we look at this, the way I describe it to patients is that if you take papillary, superficial, low-grade tumors, these tumors are very different molecularly, genetically, compared to those that are stage 1 or CIS. It's kind of like a continuum between CIS, stage 1, which then leads to stage 2. So when we start to diagnose people with stage 1 with associated CIS, we're talking about a malignant tumor that has the potential to become more invasive and spread. So that's where we're dealing with a more aggressive disease. Maggie Knowles, and who's in the UK, published a really nice review article in Nature Reviews in Cancer, which looked at the staging system. The reason why I put this in here is because one thing that patients will come in and say, I have a grade 1 or G3, T1, G3, TA tumor. Well, that's an old staging system, which was done away with in 2004, where we changed the staging system for non-muscle invasive disease to either low grade or high grade. So if your urologist is talking about grade 1, grade 2, or grade 3, they're dealing with an old grading system and probably aren't up to date. So I would tell you that the way we do it now is you either have a low grade superficial tumor or a high grade superficial or invasive tumor. So here it is, stage 1 in the lamina propria or subepithelial lining. Stage 2A, which means you're in the inner muscle of the detrusor muscle. Stage 2B is where we're now going into the almost through the bladder wall. Stage 3 is through the bladder wall into the perivesical or into the fat around the bladder. Stage 4 is when it is growing into adjacent organs. And for men, that is actually that's actually into the prostate or rectum, mostly the prostate, very, very rarely the rectum. And for women, that would be into the anterior surface of the vagina. So that's sort of the most common way that higher stage cancers present. When we perform a cystoscopy, this is the way it looks in the clinic. Which you see is, you can see normal urothelial lining, nice smooth lining, but then you see these sort of papillarily cauliflower looking, some people say it looks like an octopus tail, tails. Here you can see this is clearly abnormal. This is the characteristic sign of what a tumor looks like on cystoscopy. And once again, all urologists know what this looks like, and it's pretty easy to be able to say that that's a bladder tumor and likely bladder cancer. When we look at it underneath the microscope, low-grade tumors are going to have these nice little fronds or nice little papillary fronds. They're very well organized. They look actually very pretty. You can actually consider it I've actually seen coloring books with these things where people can color them. They're very well formed. They got a hypervascular core, and honestly, these are considered low grade. They're prone to recurrence, but not progression. So what that means is, if you have a low grade tumor that's superficial, or TA is the pathologic stage, they're prone to recurrence, but not progression. So 50% of these tumors will recur, but only 10% will progress to a higher grade invasive cancer. So I call these pesky tumors. These are just tumors that unfortunately people have to come in and have removed on a potentially yearly or even more often, or every other year, every third or fourth year. But they don't pose you no significant danger. But they do cause a lot of havoc for patients because their bladder has to be operated on. A high-grade tumor, much different. This is an example of CIS with a high-grade cancer. We're now starting to see irregularity. We're starting to see mitotic figures. We're starting to see dysformic nuclei. These are the bad tumors. These are our high-grade cancers. So when we look at the pathology of bladder cancer, 90% of all bladder tumors are urothelial cancer. The term is transitional cell carcinoma or urothelial cancer. 90%. So the majority of tumors are going to be urothelial cancer, the lining. You've heard previous talks about you're going to hear talks about upper tract transitional cell carcinoma, which is urothelial cancer that actually occurs in the lining of the kidney and ureter. So 90% of all tumors of the urothelial lining are going to start in the bladder, and 90% of those are going to be urothelial cancer. Less common tumors are squamous cell carcinoma of the bladder. These are a very different histology. They're more common in areas where you have infestation with schistosomiasis, which are worms that actually infiltrate into the lining of the bladder, cause local inflammation, and lead to cancer. And the most common is squamous cell. Other people that get squamous cell carcinoma of the bladder are people that have had chronic irritation of the bladder. Most common reason is from a chronic catheterization, where they're fully catheter or chronically catheterizing for things like a neurogenic bladder. Additionally, in between here is small cell carcinoma, small cell neuroendocrine tumors. Dr. Hoffman Census is one of our medical oncologists here at Hopkins. That's her major clinical practice and research interest, and she may even be doing a webinar for you. That's treated very differently. It's a very aggressive cancer. And then less common is an adenocarcinoma. The most common adenocarcinomas of the bladder involve the urachus. This is the one time where we actually would perform a partial cystectomy or only remove a part of the bladder. We do not perform partial cystectomies for urothelial cancers of the bladder. The only time we would do that is if you had an adenocarcinoma of the urachus. That would be the only time we would remove only a part of your bladder. There's a rare group of patients that actually have bladder diverticulums or outpouching of the bladder where you can have cancer there. That would be another example of where we would do just a diverticulectomy or partial. As it relates to management of these non-muscle invasive bladder cancers, that's what we're shifting gears to non-muscle invasive disease. By the way, when you have squamous cell carcinoma, adenocarcinomas, small cell carcinomas, these are predominantly present at higher stages, like stage 2 or higher. So those are all, unfortunately, we're dealing with giving chemotherapy, radiation, or bladder removal. Am I supposed to be looking at this chat right now? But hopefully someone asked about sarcomatoid tumors. Good question, whoever Karen is. I can't see the last name. So sarcomatoid tumors, so carcinosarcomas of the bladder. Also another variant histology. Another variant histology is micropapillary. Understand that the reason why I didn't talk about that is because those are pure urothelial cancers that then have differentiation or become a variant histology of urothelial cancer. There are a number of those. I do not have them on the list, but they would fit under, they would be underneath here, looking at, as part of urothelial cancer, variant histology. The most common are things like micropapillary, plasmacytoid. You can have squamous differentiation. You can have glandular features. You could have sarcomatoid features. These are highly aggressive cancers that, I'm talking about sarcomatoid, that present at higher stage. We typically treat those with chemotherapy, followed by bladder removal. The reason why people develop sarcomatoid bladder cancer is they've oftentimes been exposed to radiation therapy as it relates to prostate cancer, and they have this de-differentiation of their cancer. As it relates to non-muscle invasive bladder cancer, low-grade tumors, The good news is we remove them. We typically give perioperative chemotherapy, which means we just put a form of chemotherapy. Nowadays, the most common is gemcitabine, helps reduce the risk of recurrence. And then we just follow things. The only time we start to give intravesical treatment, and I'll go over that more in a minute, for low-grade cancers is if you start to develop multiple tumors that recur within 12 months. That would be considered a cancer that we then start to treat with intravesical therapy to prevent those recurrence rates. High-grade cancers, either CIS, high-grade papillary tumors, or T1. These are at a high risk of recurrence, greater than 50%, but more importantly, they are at higher risk of progression to muscle invasive, in particular those that are stage 1. This is when we start to use predominantly use intravesical chemotherapy and immunotherapy in the form of BCG, which I'll talk about more in a second. So when we stratify bladder cancer, let's just make this simple. You either have non-muscle invasive bladder cancer, which is early stage disease, or you have muscle invasive disease. Remember, 70 to 75% of all people presenting with bladder cancer are going to have non-muscle invasive disease, and about a quarter will present with muscle invasive disease. Non-muscle invasive disease, low grade or high grade. If you have muscle invasive disease, is it localized with no signs of cancer spread, or is it metastatic, which is where it spreads outside the bladder to other places in the body? I believe that you've had a webinar on this. The focus of this talk today is not to talk about management of metastatic disease. That would be done by one of my colleagues in medical oncology. So let's talk about the bladder cancer as it relates to the different strata. So non-muscle invasive bladder cancer, this is a disease that the urologists manage predominantly or exclusively. The mainstay treatment is a resection of a tumor where you're put asleep. A scope is placed inside your bladder. You can see it here. Here's your tumor in the bladder lining. And at the end of that scope, you have actually a knife or a loop that cuts and scrapes and removes the tumor. The purpose of doing this is we want to be able to understand what the configuration of the cancer is, where is it located, what is the size, how many tumors are there, and most importantly, and this is honestly the most important part and really the way that we decide how we're going to treat it, is we want to send it to our pathologist that will provide us with the stage. So is it T1? Is it CIS? Is it stage 2? Is it papillary, stage TA? What is the grade? Is it low grade or high grade? Does it have that variant histology like we heard from a question from Karen asking about sarcomatoid? And is there something called lymphovascular invasion? So lymphovascular invasion is when the tumor starts to locally involve the lymphatic channels around the lining of the bladder. So all of these things help us decide what your next treatment options are, what your treatment options are. So as it relates to non-muscle invasive bladder cancer, I think I've beaten this to death here. We're here at low grade and high grade. And we really need risk stratification allows us to enable patients to give them personalized treatment decisions. And I'll go over that more in a second. Honestly, right now, our predictive models to predict who's gonna respond to treatment, who's gonna go on to progress is really lacking. And that's where the future, and that's where a lot of our research efforts are focused at this point. As it relates to guidelines, I think it's important that I point out that that the guidelines for the AUA and the NCCN, which is the National Comprehensive Cancer Network, do recommend enhanced cystoscopy when patients undergo a TURBT. There are two forms of enhanced cystoscopy. One is called Cysview, which is blue light cystoscopy. The other is narrowband imaging, which is where you're able to use a filter on the scope to be able to identify tumors. As it relates to narrowband imaging, good for picking up papillary tumors, not good for picking up a CIS. And all of the trials that looked at narrowband imaging showed that it only helps reduce recurrence. It does not help reduce high-grade cancers. As it relates to blue light cystoscopy, very different. It picks up high-grade cancers and helps pick up and helps reduce high-grade recurrences. So this is now part of my standard practice and standard of care. I've been doing this now for 10 years, offering this, and it's now in the guidelines. The NCCN also agrees that this is helpful in identifying lesions. They do not have such a rigid stance as the AUA, but this is becoming mainstay as it relates in the treatment of non-muscle invasive bladder cancer. So results as it relates to staging, we as urologists really have to do a good job of staging the cancer because it's so important. We want to be able to delineate stage 1 from stage 2, or from early stage papillary disease to invasive disease stage 1. And what we do is, you will oftentimes hear your urologist say, listen, ma'am, listen, sir, we need to do a restaging exam. Restaging exam is important because patients with, especially with stage 1 cancer or multifocal CIS with high-grade cancers, when we do a second TUR, we find a residual cancer in that bladder, upwards of 50%. Most people would say 30%. And most importantly, when we do a restaging exam in patients that have stage 1 cancer, we actually find about 20% are upstage to stage 2. This is super important for 2 reasons. Number one, if you fall into the 30% that have residual cancer, then guess what? You know, and those aren't removed, your intravesical treatment is going to be less effective. And if you are in the 15 to 20% that are upstage to stage 2, then we're under-treating you. We're actually giving intravesical therapy when you should be getting potentially chemotherapy, radiation, or bladder removal. So proper staging and restaging exams are mainstay and need to be done for patients with high-grade disease. As I said before, intravesical therapy for high-risk non-muscle invasive bladder cancer. So high-risk non-muscle invasive bladder cancer is people with CIS, high-grade papillary tumors, or high-grade T1 tumors. I'd like to point out that this is what I use in my clinical practice. There are other options. The reason why I use these 3 agents in my practice is because there's the most evidence and to support their use, and they're the most effective. BCG, we'll talk about in detail. Chemotherapy like gemcitabine and docetaxel, combination chemotherapy, we now know is more effective than single agent chemotherapy, things like mitomycin C. So this is what we use now in our practices. And I'll point out just right now, because I think just to make the point that if you fail BCG, or if you fail BCG and intravesical chemo and you want to save your bladder, there really is no other options. You should be thinking about a clinical trial. And this is where a lot of our efforts are focused at this point, coming up with nice, novel clinical trial options for people to preserve their bladder that have BCG unresponsive disease. As it relates to BCG, it's sort of a historical perspective. I think it's important to point out that this was actually one of the first immunotherapies used to treat solid tumors. You know, it's been used now going on 50 plus years. It was used for the first time for bladder cancer in the mid-70s. Alvaro Morales, when he's a Canadian and working in DC at the NCI, essentially was the first to use this. Mark Soloway from Miami, working at the NCI, was also one of the early adapters. And I'd like to point out that, believe it or not, even though we've been using this since the mid-70s, it's still the first-line treatment and still the most effective treatment. I would argue that we need to consider other things at this point, but right now it is the most effective. Oh, by the way, it's a live attenuated mycobacterium. It was developed as a vaccine for TB. It has significant anti-tumor activity in several cancers. Believe it or not, one of the first cancers it was tried on was melanoma. It was ultimately not used for that because they thought that they would have more effective treatments, but now there's sort of a shift back to potentially using it. And this is always given within 6 weeks after transurethral resection of bladder tumor. As it relates to efficacy of BCG, you know, unfortunately, 30% of patients with non-muscle invasive bladder cancer that are high risk, that have these high-grade features, as I talked about, CIS, stage 1, lymphovascular invasion, they're unresponsive to BCG. So BCG fails them. At this point, we know, and I'll drive the point, if you compare BCG to intravesical chemotherapy in the BCG naive population, which means people that have not been exposed to BCG, every trial has shown that BCG or immunotherapy is more effective than intravesical chemotherapy. We can talk more about that. There are better ways to deliver chemotherapy, like with nanoparticles, with heating the mitomycin C to get better tissue penetration. So that's sort of being revisited at this point. The reason why BCG unresponsive population is such an important population, because these are the people that are at risk of progression to muscle invasive disease and ultimately potentially metastatic disease. So we need to come up with nice treatment options for them. And that's where sort of clinical trials and doublet chemotherapy have been used. I know Dr. Cates went over a talk on BCG shortages. I'd just like to point out that the BCG shortage, unfortunately, is a problem here in the United States as well as globally. And hopefully that will subside shortly. The good news is that Merck has agreed to start sort of opening up another plant, consider doing more manufacturing of BCG. I suspect that's the case because they now have a lot more interest in bladder cancer. Their company is very much interested in treating bladder cancer, urothelial cancer. They actually have an FDA-approved treatment for BCG unresponsive disease called pembrolizumab. So I think that this is something that I'm hopeful that Merck decides to make this a priority. There are different strains of BCG that have been used around the world. We know that BCG TICE, which is the strain that is made by Merck, is the most effective. And this has been shown in clinical trials when you compare them. There's just an example of that. I'd like to state that right now there's a nice trial in the United States going through the Southwest Oncology group by one of our colleagues and friends, Rob Svitek, in where we are comparing, his trial is comparing BCG TICE strain to the BCG Tokyo strain. This is a registry trial with over 700 patients. The goal here is to show that the Tokyo strain is hopefully not inferior to TICE, so this can be opened up here in the United States so we can have more access to it. And also that trial is looking at the concept of priming, so you pre-vaccinate patients with BCG, see if you get more of an immune response to see if that's more effective. I'd like to spend a second about maintenance therapy. This is part of the standard of care. Maintenance therapy is when patients with high-risk non-muscle invasive bladder cancer undergo treatment for their bladder cancer with maintenance BCG. A trial that was published by Don Lamb in the 80s demonstrated that if you received maintenance BCG, which is given at 3 months after you finish BCG induction, which is the 6-week treatment course, you're given maintenance, which is 3 treatments, so weekly for 3 weeks at 3 months, 6 months, and then every 6 months for a total of 3 years. You can see in this Kaplan-Meier curve, here's the people who did not receive maintenance. You can see that they drop off, they get more tumor recurrences versus those that receive maintenance, okay? What this tells us is that your recurrence-free survival, if you did not receive maintenance therapy, is 36 months, whereas 77 months for those that did. This is, once again, standard of care. This is in the guidelines. Unfortunately, when the BCG shortages, we're not able to provide this to our patients on a routine basis. So we're hopeful that new BCG formulations or manufacturing will allow us to do that. What is your typical post-treatment monitoring after BCG? Most bladder cancer patients know this, at least those with non-muscle invasive disease. Every 3 months from the diagnosis, from finishing your intravesical treatment for 2 years. Then it's every 6 months for 2 years, and then yearly thereafter. If you develop a recurrence, starts the clock over, okay? And this recurrence pattern, the monitoring that I'm showing you, is for people with high-risk non-muscle invasive bladder cancer. If you have low risk or low grade cancers, thankfully, we get to stretch that out to yearly pretty quickly within the first like 12 to 18 months. Importantly, patients don't realize, but they have to have CT urograms, which are CT scans to look at the lining of the kidneys and ureter every 12 to 18 months, especially within the first 5 years of diagnosis. And then we as urologists oftentimes will get urine samples at the time of your cytology. I said earlier, it's not the best test, but it's all we really have at this point. There are some newer urine tests that are being used. However, their utility in the surveillance population has not been established. This is just for me to remember to tell you that the combination of gemcitabine and docetaxel, which is your sequential intravesical chemotherapy, which is where we give it weekly for 6 weeks and then monthly for 2 years in patients that have failed BCG, or BCG has failed the patient, or we don't have BCG available. We have shown, as well as the group out of Iowa, as well as a multi-institutional group has shown, and this is the most important point here is that at 2 years, believe it or not, 50% of people are still disease-free. And this is a durable response. This is the best data that we have. It's actually highly effective. What I will tell you is that this is becoming very common in multiple bladder cancer practices around the country today. I'm not going to talk about any additional treatments, only because hopefully within the next maybe 3 to 6 months, maybe year, we'll have 2 new intravesical treatments for BCG unresponsive disease in the form of a gene therapy that overexpresses interferon, is called nanofaragin, as well as Vicinium, which is another intravesical agent that is used. I'm happy to take questions about that. I will tell you that there is an FDA-approved agent called pembrolizumab or Keytruda, which is used in BCG unresponsive disease. Unfortunately, its effectiveness is very poor. Less than 20% of people actually have a durable response at 12 months. So it's really not it's not utilized very often in practice, essentially. So what are the take-home points? Intravesical BCG is highly effective and more effective than intravesical chemotherapy in the BCG naive setting. Maintenance BCG reduces recurrences, and I would make the plea that we need better intravesical agents for management of non-muscle invasive bladder cancer. I would say that the first step for that is the intravesical doublet chemo, and I think I'd say that some of the newer agents that hopefully be FDA approved will provide us with that. Shifting gears to muscle invasive disease, in particular localized muscle invasive disease. The sort of options for patients for muscle invasive disease are here. What would be considered the gold standard is neoadjuvant cisplatin-based chemotherapy followed by bladder removal. So what does neoadjuvant mean? It means that it's given prior, so chemotherapy is given prior to bladder removal. Bart Grossman published in a large randomized controlled trial almost 20 years ago that if you use cisplatin, which is a form of chemotherapy, and gave this prior to removal of the bladder, you prevented metastasis or cancer spread, and there was an overall survival benefit. So this has become standard of care. However, there are patients that are not able to receive cisplatin due to potentially people that have hearing loss, people that do not have very good kidney function, who then we need to take their bladder out then. And then what we can then do is make decisions about adjuvant chemotherapy or other agents that are now being approved or being used and studied in this population. Trimodal bladder preserving chemoradiotherapy, another option. I'm going to talk about that in detail in a second. This is a underutilized option. It's underutilized for a couple of reasons. I think it's underutilized because we know what patient population it works in. However, that patient population is very narrow, so we oftentimes will not expand it of concern that it's not going to be effective. and I'll talk about that more in a second. A radical TURBT is where we say, you know what, this patient is unfit for cystectomy, they're unfit for chemo or radiation, and we're just going to go in every so often and just scrape out the bladder lining. I can tell you this is ineffective, but does help control symptoms in patients that have a short life expectancy. As it relates to bladder preserving trimodal chemoradiotherapy for muscle invasive bladder cancer, I'd like to drive the point that that urologists are also need to be very involved in this. The reason why is that prior to starting any chemotherapy and radiotherapy to the bladder, you need a maximal TURBT. We know that the success of trimodal or TMT therapy is a thorough TURBT to get rid of any residual microscopic cancer or gross cancer that's present. It's then followed by daily radiotherapy for upwards of a month given radiosensitizing chemotherapy. There's different regimens that can be done. Oftentimes it does involve cisplatin. The utilization of chemotherapy, like in the neoadjuvant setting prior to this, is being studied. I think you've got people around the North America as well as around the world that feel strongly about that. And once again, we can talk about that more if you'd like. If you do bladder preserving therapy, you have to recognize that you need lifelong surveillance cystoscopy and axial imaging to see if there's any signs of any recurrent disease. Obviously, this is exciting. We want to be offering this to patients because an organ preserving approach is very much needed. And this is the case for any cancer. What I'd like to point out is that there are no randomized controlled trials that compare radical cystectomy to bladder preserving chemoradiotherapy or TMT. And we know that that if you look at patients that underwent bladder preservation, these are select patients, but their survival outcomes are equivalent to that of radical cystectomy. So who are those patients that have equivalent outcomes to bladder removal? Well, those are people that have solitary smaller tumors, usually less than 5 centimeters. Some would even say less than 3 centimeters. They have no signs of any higher stage cancer or something called hydronephrosis, which was indicative of stage 3 or higher cancer. They have to undergo a maximal TURBT with no visible disease present. These are they're not strict contraindications, but we don't like to see people that have failed non-muscle invasive bladder cancer and gone on to muscle invasive bladder cancer. These people really don't respond well. They have local recurrences. And people that have CIS, and once again, not a strict contraindication, but we oftentimes, it's very much debated if CIS, if you can treat people with chemoradiotherapy that have CIS. We know that radiotherapy and chemotherapy does not treat CIS. So if you have a patient that has CIS, those are people that are going to have chances of recurrence, local non-muscle invasive bladder cancer recurrences that are high. Recurrence rates in the bladder after trimodal chemotherapy, trimodal chemoradiotherapy, are as high as 50%. I think if you select the right patient, it's probably less. But when you start expanding the indications, it could be as high as 50%. And about 20 to 25%, so 1 out of 4 people that undergo chemoradiotherapy or TMT will need a radical cystectomy or salvage cystectomy due to either high-grade recurrences or progression to muscle invasive disease. As it relates to neoadjuvant chemotherapy, as I said before, it's important because it does cause downstaging of your cancer, which is an accurate predictor of outcome. And it gives us an opportunity to study biomarkers that would predict response to neoadjuvant chemotherapy. There was a clinical trial that is now done. Once again, a cooperative group trial that looked at, it was a biomarker study that compared 2 neoadjuvant chemotherapy regimens. The 2 that were compared was gemcitabine and cisplatin versus MVAC, which is a 4-drug combination. The results are still pending, but what we're trying to figure out is can we develop biomarkers that are predictive of response or even prognostic? I think that the field is looking for that. once again, I hate to say it, but I don't feel like we're there yet. I don't think that this is something that that we can, once again, hang our hat on. We're not able to do that. As it relates to radical cystectomy, this is very effective. It gives you excellent local control rates, cures many people, and it does give you your best chance for long-term survival. However, you know, it is not effective in everyone. And what surgery does is it provides accurate pathological staging of the primary tumor and the regional lymph nodes. This helps allow you to be more precise with your additional adjuvant therapies. The shortcomings is that it does mean you have to undergo a urinary diversion or urinary reconstruction. The most common diversion is an ileoconduit, which is an incontinent diversion. This is 9 out of 10 people will choose this diversion. It's very effective, very easy to manage. The majority, 10% of people will choose a neobladder or orthotopic neobladder, which is where we use your ileum or bowel to make you a new bladder. These are the predominantly, 99.9% of patients will choose this. Complication rates are high after cystectomy. If you look at all complications, the complication rate is 70%. But if you look at those that are considered major complications, about 30% of patients, unfortunately, will have a major complication. Those are usually related to infection, problems with urinary reconstruction, like with leak of urine, or the second most common is bowel dysfunction. And we're happy to discuss that more. So what is the future? Well, I'd say the future is that tissue and urine-based biomarkers to predict response to both muscle-invasive and non-muscle invasive bladder cancer is what we need to come up with. We need to come up with better intravesical and systemic options to be used in non-muscle invasive disease, as well as in the neoadjuvant and adjuvant setting, as well as metastatic disease. And I'll tell you what is not standard of care, and this is what's important. It is not standard of care to have genomic evaluation of your tumors, especially as it relates to localized bladder cancer. If you have metastatic disease, that's a completely different story. And that, I would say, is, I believe, standard of care, because this helps choose what systemic options are available. I will end there. I have no idea how long that took, but hopefully that was helpful. And I'll take questions if you would like.
Thanks, Trini. That was outstanding. We've got a couple of questions that came in. One of them that you already answered related to sarcomatoid tumors. Just corollary to that, how common do you think sarcomatoid tumors are?
Clearly, this person must have a sarcomatoid tumor. They are uncommon. If you look at all comers, it's probably less than 10% of urothelial cancers that develop this variant histology. It is known to be locally aggressive and recur, both in the bladder as well as distantly, so develop metastatic disease. And I will tell you, the #1 risk factor for developing a sarcomatoid tumor is previous radiotherapy or radiation therapy. That's where we see it the most.
Thank you. And then another question from Maddie and Morgan. Is there anything new for surveillance for high-grade non-muscle invasive bladder cancer? And I guess correlated to that one is, why is blue light cystoscopy not routinely used?
Well, the last one's easy. I would say that it is routinely used in my practice and the urologists here at Hopkins. In the community, it's becoming a lot more routine. And I will tell you, the community physicians, other academic centers are really catching on, and they're really using it. I think one of the limitations to using it, I'll be honest with you, is related to finances. It does increase. There's some capital finance that the institution, the surgery center, the department, the hospital has to put up. One of the reasons why it's not used often is that you do have to have the Cysview placed inside the bladder prior to surgery, so it is an extra step. It does take time to get the workflow together. So I think for some it's just challenging. It's difficult. So I would say, though, it's becoming a lot more routine. First question you asked me, I'm sorry about.
Is there anything new for surveillance?
Yeah, I mean, not for surveillance. There's some new biomarkers that are urine tests that are now being sort of used in hematuria workups, but not for surveillance.
So we had a few questions come in via email, but another one just appeared in the chats from Ann Hoffman. What treatments are available for overactive bladder following successful treatment with BCG?
Yeah, so Anne, God, I wish I could give you some wonderful answer to that. The what we oftentimes use. So first of all, if everybody has an overactive bladder, when I say everybody, sorry, that's a gross overstatement. There are patients that have overactive bladders as it relates to intravesical treatment. BCG is more common than with chemotherapy. It is self-limiting, and what I mean by that is it typically goes away. Could take 6 to 8 weeks, could take 3 months. If it is occurring long term, the most common way to treat it is with things called anticholinergics or antimuscarinics, or a class, the beta agonists, which are drugs that essentially relax the bladder, so it's not so reactive, and they don't have to go to the bathroom as often. That is by far the most effective way to treat it. But typically it's self-limited and it goes away once the bladder has quieted. I think all the inflammation and all the everything that's happened really does wreak havoc in the bladder.
From Sal Dunn, so if you find a low-grade cancerous tumor several years after final BCG treatment with no tumors seen, does BCG still have any role as a treatment?
If it's a low-grade superficial papillary tumor, stage would be TA. I would not use BCG ever again in that cancer. BCG is only used for high-grade cancers. It's not used for management of low-grade disease.
Thank you. Any more questions in the chat or the Q&A from the folks who are online now? Otherwise, I'll turn to some questions that came in via email. Okay. Trinity, are biopsy reports generally uniform, and are they generally accurate from one institution to another? Are they generally the same coming from a small community practice in an academic medical center?
Great question, because it was relevant to actually 2 patients that I saw today. So the pathology report is oftentimes not uniform in the sense of the way that they report. Some practices could be in the community, could be academic. Let's be honest. We'll have a report that is generated by the pathologist, so it may have all the information in there, but it's not very clear. Okay. In community practice, I would say, there's oftentimes potentially more a possibility that you would have a inaccurate assessment of the pathology, and the reason why is not because they're not good pathologists. It's not because they're not doing a good job in trying. You got to understand, in community practice, that you have a pathologist that is actually reading prostate biopsies, breast biopsies, colon biopsies, lung biopsies. They're doing everything, and they're not super specialized. Whereas when you come to an academic institution, and there's many around this country, you are going to have devoted pathologists, GU pathologists that know sort of the up-to-date how to accurately assess this. They provide us with stage, grade, variant histology, things like lymphovascular evasion, presence of CIS, and it is uniform and it's very clear in the pathology report. As it relates to community practice, other academic institutions, but I would focus on community practice once again, because I think I'm not picking on them, but it's just hard. It's about 20% of the diagnoses will change or have something different when they're reviewed here at Hopkins. Okay. And that's for sort of all of the sort of biopsies and things that we get.
Thanks. And I guess related to that, at what point should a patient request a second opinion on these reports?
I gotta say, if there's anything that's unclear, or if you ask your urologist or medical oncologist, whoever you're working with, to say, what's my stage and grade, and they look at their pathology report and say, I don't know, I can't tell, then you're in trouble. I would get a second opinion. If they say, oh, you have an unusual tumor, it's very rare, get a second opinion. If you're getting multiple recurrences, or you're sort of failed treatment, or the treatment has failed you, and you're getting, maybe get a second opinion as to what's going on. Those are sort of times when you do that, but there's no clear-cut answer to that question.
Thanks. And then I guess on average, maybe you can answer this for two types of non-muscle invasive cancer. For low-grade bladder cancer, how long does it take, or how frequently does it jump to high grade if left untreated? Is that months or years?
Good question. As it relates to low-grade cancers, right? So low-grade, superficial, papillary, TA tumors, right? Clear what that is, right?
Yep.
Low-grade your risk of progression to high-grade cancer is in the order of 10%. I would argue that it's not the low-grade tumor that's progressing. It's probably a field defect and another high-grade tumor that just hasn't occurred. But if you look at all comers with low-grade disease, it's about 10%. Some studies would suggest it's higher, like 15%. But I think 10 to 15% is a good call.
So what about for high-grade non-muscle invasive cancers like CIS or T1 disease?
So it's all dependent on, I'm sorry, go ahead, David.
Go ahead.
Please finish, I'm sorry.
Okay, so for risk to jump to muscle invasive disease, time, percentage?
Yeah. So sort of some nice, just sort of ballpark figures, right?
Right.
If you look at all comers with high risk non-muscle invasive bladder cancer, the people that I'm talking about right now are people with CIS and stage 1 disease, right? That's the dangerous disease. If you look at all of those people, at about 2 years, you've got very few that have progressed to muscle invasive disease, okay? In the order of 15 to 20%. So not a lot, all right? But if you look at recurrence rates, it's 50% are gonna recur, okay? And if you then take the people that recurred early, with high stage, T1 disease, then your progression rate in that patient population is upwards of 50% within 2 years, right? So it all depends on when you recur, how you recur, sort of where you are in that continuity, in that continuum. So it's hard to give you ballpark facts. One thing to remember is about a third of people that get BCG are cured. That I think everybody would agree with. And then the rest, which is unfortunately like 70%, 75%, are going to recur and progress. And those are the people that we're just constantly treating, following.
So Ann Hoffman has another question, which is probably related to another question that came in via email. So she asks, why were you so emphatic about no genomics for bladder cancer?
I didn't say no genomics for bladder cancer. I said no genomics for non-muscle invasive bladder cancer. I do think that, unfortunately, there are patients that come in and believe that a genetic or analysis, genomics of their or somatic mutations, right? Where you're looking at mutation frequency, what they are, what are these mutations in non-muscle invasive bladder cancer, is going to help treat them and come up with a treatment regimen that's going to guide their treatment. And this, unfortunately, is out there right now, and people are coming in saying that they need this done. It has to be done. And the reality is there is zero evidence to say that we need to do that right now. I think for metastatic disease, there's plenty of evidence. For muscle invasive bladder cancer, I think you could argue that maybe one way or the other, but I think for non-muscle invasive disease, not at this time.
So I agree with you. And you know, Trinity and I are both working on that right now. Chances are, if you come to Hopkins and you're getting BCG or chemotherapy for your disease, chances are we're going to sequence you, but it's not standard of care. So people are not making decisions based on that. And then a corollary to that, Trinity, so in the email, there's a question about your August 2020 European Urology paper.
Oh,
And
God. Are you kidding me? Jesus,
nope.
who asked that?
I'm not going to tell you. Yeah.
Tell me, who asked that?
Stephanie Greenberg.
Oh, come on, Stephanie. Don't do this. Come on. All right. What do you want to know?
So tell us about that. Maybe that might be
Oh.
partly why we're skeptical now about using genomics for.
Oh my God. Do we have to do this? We're opening up a can of worms. Okay, Stephanie, apparently Dr. Becker, who was the first author in that, told us that our letter to the editor just got published today or something. So you'll see what we think. So what Stephanie is talking about is we recently published a paper where we critically evaluated what we defined as a restaging exam after a patient with muscle invasive bladder cancer received chemotherapy. We sort of, over the years, we've asked the question, is there patients that we can potentially save their bladder and say, you know what, it is safe to save your bladder and not remove it after getting chemo. And there are reports in the literature of people that have successfully done that. By looking at clinical factors like what does the bladder look like after chemo, biopsies, and then to the point that we were just asking about genomics or looking at a genomic evaluation of the tumor prior to receiving chemotherapy, that there were some mutational changes that occurred in a specific group of genes that are called DNA mismatch repair or DDR mutations. And I'll be accurate here, David, in case there are people that are listening, but that are those that are actionable mutations, right? Deleterious. Could we genomically study these tumors, combine that with our restaging exam, and then say, these are patients that don't need their bladder, okay? Make a long story short, we did that. We looked at bladder cancer patients' tumors prior to receiving chemo. We looked at our restaging exam after they received chemo, and we congregated all this data and then correlated it to their final pathology at cystectomy. And guess what we found? That we are not, at least in our hands, in our cohort here at Hopkins, that we are not able to predict response, both clinically and genomically. So some of the things that are being said out there that patients can preserve their bladder, I personally believe that we may be overstating that. I do believe that there are patients out there that we probably can, but we have to figure out who they are, and our current tools are not there yet to do that.
And I'd agree with that too. There's another paper from our Danish friends who concluded the same thing.
Exactly. But no one talks about that. You notice that, David? Never mind.
They're starting to.
They're starting to, but
yeah.
I'm glad. I think it's because people like you are talking about it.
Thanks. So Karen Saxa says, is there an oncotype available for bladder cancer?
No. That's what we just said.
We're working on it, Karen. We're still working
exactly.
So one thing we can say is that this Coxon trial that Trinity referred to, there's a paper under review right now. We tried using various approaches to predict downstaging, and so far none of them worked. So unfortunately, we're going to have to wait for the survival outcomes data to know whether or not we have a reliable biomarker to predict patient outcomes in terms of survival. But bottom line is that there's more work to be done in identifying biomarkers for either prognosis or predicting response to various therapies.
And I just to clarify for maybe people that are on the line that don't know what oncotype is, it's a way where you essentially look at a panel of genes that are mutated in a cancer, and then use that to help guide treatment. Common in breast cancer, for example. But there really is not one. That, to be fair, there is something that you could do if you underwent a cystectomy and did not receive chemotherapy. There is a commercially available tool that is used potentially to try to guide adjuvant treatment. I'll be honest with you, in clinical practice, it's really not used.
So let's see if there are any other questions. Last call for questions. Well, again, Trinity, thank you very much for joining us today, and thanks all of you for joining us, and hope that you have a very safe Thanksgiving. Try to be cognizant of all of the safety recommendations around you. If you're wondering what they are, let us know. We'd be happy to email you what we're getting here at Hopkins. But wash your hands, social distance, and wear masks, please. And happy holiday.
All right. Thank you.
Thanks, Trinity. Thanks,
Bye-bye,
everyone.
guys.